present Dr. Srisha Herber from the University Hospital of North Midland. Hi, Srisha. Nice to see you. So the floor is yours with the stone management basics and beyond.
Thank you very much for the invitation to the ESG and Fujifilm. Right, so I'm going to talk about the stone management. So we know that with the advent of MRCP and the endoscopic ultrasound, so the ERCP has become more of a therapeutic procedure, and thankfully we don't use ERCP to diagnose bile duct stones. And in this study, which looked at the trend of in-hospital diagnostic and therapeutic ERCP in the United States, we can see that in a decade there has been a 2/3 decrease in the number of diagnostic ERCP, the blue line, as compared to what it was about 10 years ago, which is a good sign. So, but then but we know that with the advent of imaging, so we are using lots of CTs, we are using a lot of CT colonography, we are picking up more and more bile duct stones in patients who don't have any symptoms. So his first question we need to ask is the patient affected by the bile duct stones? So we know that a lot of patients have gallstones, and we don't go ahead and do an cholecystectomy for these patients. So if they don't have any symptoms, what do we need to do with these bile duct stones in asymptomatic patients? So the guidelines with the ESG and also the BSG at the moment suggest that even with the low evidence, that we should offer ERCP for these patients, even if they are asymptomatic. But the limited evidence, what we have at the moment, shows that in this study, which looked at the natural history of asymptomatic bile duct stones, in those patients who had an intervention like an ERCP, they had a risk of pancreatitis about 20%. And in those patients who did not have any intervention and had a wait and watch policy, and they had a risk of cholangitis of about 20%. So on both sides, you have some risk with asymptomatic bile duct stones. I'll give you my personal little bit of a story. So this was a patient with a 70-year-old who had a chronic diarrhea and had a CT colonography which picked up multiple CBD stones. She was completely asymptomatic. Liver enzymes were all normal. The diarrhea which she presented with settled down with change of insulin. Based on the fact that she had multiple stones, she went on to have an ERCP, which turned out to be a difficult one, and this patient developed severe pancreatitis. So I think it's very difficult for the patient and the relatives to deal with when they know that they had an intervention for which was only picked up by chance and they didn't cause any problem. And also it's difficult for us to justify that as well. So what do we do at the moment? So first important thing is that this is not an emergency. You have time. The patients are not symptomatic here. So it's important to review the patients, assess if they have got any symptoms, review the bloods over the last few months to see if there has been a raised liver enzymes every now and then offer ERCP only if the patient is symptomatic or had altered LFTs. And it's important to have a detailed discussion about this with the patient and the family. The other issue which comes about is that now you found stones through imaging. The patient was symptomatic, patient had cholangitis or else pain. By the time that they came for an ERCP, the patient's symptoms are better. The liver enzymes have started improving. So what do we do in this situation? So you just give an example, a 51-year-old who had cholangitis and bilirubin was 91 with obstructive pattern, 2 stones were seen in the MRCP. 3 days later came to the ERCP, but then the patient said the symptoms are all fine now and the liver enzymes have improved. So do you go ahead and do an ERCP in this patient? Well, in this patient we did, but we learned a lesson. So you can see that there's a fistula on just above the papilla and both the stones had fallen off. Thankfully, this patient did not have any complication. But if you look back, we could have managed this patient something differently. The patient has been well. So and the patient has gallstones. This is a young patient. This patient will definitely need a cholecystectomy. So this patient could have gone, we could have canceled the ERCP and say that you need a cholecystectomy. And then based on what we find there, we can decide whether you need an ERCP or not. So, or we could have done an alternative approach. So what we are doing at these now with these kind of patients, we are offering an endoscopic ultrasound just before we do an ERCP in the patients who have a low risk for bile duct stones. That is, patients in whom imaging had confirmed bile duct stones, but by the time they came for an ERCP, their symptoms are better or their liver enzymes are improving. Or in situations where the MRI ultrasound CT had showed that there is suspicious of stone based on the fact that there is dilated duct, liver enzymes been slightly altered, and then they thought there were stones, but they were not completely sure on the imaging. Or patient had a cholecystectomy and had an on-table cholangiogram, which showed a tiny stone, but the patient has been well when they came for an ERCP. So all these patients, we do an EUS just before doing an ERCP. And if you look at it, in the sense that we are looking at low-risk stones, so the EUS is relatively very quick, because you're only having a focused examination of a bile duct, and then you're looking for either 1 or 2 stones. And then we found that in majority of the patients, almost close to 50%, patients did not have stones, and then we canceled the ERCP. We followed these patients of about 185 patients, which we had for about 6 months as well after the cancellation, to see whether they came back with a cholangitis. And only 3 patients came back, and those were the ones who were waiting for a cholecystectomy, or 1 patient who was deemed not suitable for cholecystectomy. So EUS before ERCP is good for this approach. So how do we manage CBD stones in those who have? So there's not one approach. We have to think about all the different approaches. So there is a preoperative ERCP in those patients whom we think might not be suitable for a cholecystectomy, or patients who have been really unwell with cholangitis, or patients can have, if they've been well, they can go for a lap cholecystectomy and can have an ERCP afterwards. And there's also an option that as an intraoperatively during cholecystectomy, young patients who have got dilated bile duct and has got a stones can, in an experienced hand, can have a bile duct exploration and stone removal at the same time as well. So they don't need another procedure like an ERCP. Or after the cholecystectomy on table, they can have an ERCP. Or in certain countries like in Sweden, or Scandinavian countries, they do rendezvous techniques. They do a post-cholecystectomy, put a wire through the cystic duct, and then ERCP, somebody catches the wire from the other end and do an ERCP at the same time. So there are different options which you can think of. Now, coming to a situation where you've decided that the ERCP is the right option for this patient, in this situation, removing the stones all at one go might not be the option. For example, in some situations where an emergency situation, just draining is the option. For example, patient has got a severe cholangitis, septic, they are in ITU setting. You don't want to spend a lot of time to remove all the stones. So it might be that you want to just put a stent in, drain them, and then come back another day. Or in patients who have got severe cholangitis, but they're on anticoagulants, so you can't do a sphincterotomy or a fistulotomy, so you just have to put a stent and come back. Or patients who are not on propofol, they're just on a sedation, but they're not tolerating, then again, you have to bail out very, very quickly. But in all of the situations, well, just to show this, so this was a patient, you can see that patient was on rivaroxaban, had a cholangitis, was septic, hypertensive. Your aim was to just put a stent and come back. So slightly difficult in a way that there is a diverticulum on both sides, but actually when the ampulla is in between the 2 diverticulums, sometimes it's easier to cannulate. So once we've cannulated it, so we're just putting a pigtail stent in. But then again, if you just put one pigtail stent in a situation where you have not done any cut, then actually it might get blocked because the bile doesn't drain to the pigtail stent. It drains around the stent. So putting 2 stents in situations like this where you have not cut the papilla helps because the bile will drain between 2 of these stents. Right, so what about the patients who we think that we have decided that this patient needs an ERCP and the patient is not in an emergency situation? The guidelines suggest that we should be clearing the stones in these patients in about more than 75% in first attempt. So this study was looked at the hospital episode statistics of all the ERCPs in the country for 2 years. And this showed that only about 6 to 9% of patients had a complete clearance of stones in the first go. So still still about 30% are having about 2 or 3 ERCPs for clearing. So what is our effective stone withdrawal technique? How can we make sure that we clear the stones in the first attempt and without any problems? It's important to understand what's the size of the stone and what's the size and the shape of the bile duct, whether it is completely straight or whether there is any tapering of the duct, and also what is the papillary size of the papillary opening. To understand how much cut you can do at the papillary opening, it's important to understand the morphology of the ampulla. You need to know what is the infundibulum, till what is the level you can cut. Sometimes you can't just make it out when you see the papilla. You have to make a little bit of cut, put the sphincterome again in, pull back and reassess, and then decide how much you can cut. For example, now I can just show you the next video of, you can see this, there's quite a large intraduodenal portion of the bile duct. And here, and this patient had a large stone. So it was important in this that we don't do a small sphincterotomy. Then if you put a bigger stone trying to troll that in a small sphincterotomy, you're going to cause problems. So it's important that the sphincterotomy is very, very effective, but you need to know till where is the limit where you can safely cut. So cut a little bit, put the sphincterome back in, bow it, pull back, reassess to see how much more you have got to cut. Here, I think we've just done, that's the limit. You can't go more than that. That's and if so, in this situation, we've done quite a big sphincterotomy because it was quite a large intraduodenal portion, and you can see a large stone was effectively delivered in this case just with sphincterotomy. But in certain situations, you might not have such a large intraduodenal portions. You might have a smaller ampulla, but then you got a larger stone with a dilated duct. In that situations, you might have a sphincterotomy and then do a sphincteroplasty to the size of the duct. So and then that will be effective technique to remove the stones. Or in situations like you have where you have a ampulla in the periampullary situations. Here, you have to be really careful because the infundibulum is not very marked. You don't know exactly how much to cut. What's the limit of it? So in this situation, it's much more safer to do a small sphincterotomy and a sphincteroplasty, even if you're dealing with the smaller stones. And this will be a much more effective technique to remove stones when there is a ampulla in the periampullary diverticular setting. In these situations, now that you've got a large ampulla, you know that there's a stone sitting just underneath that. In these situations, it's much more effective to go for a primary fistulotomy sometimes. So you can see as soon as you cut, there's a stone underneath that. And if you've never done a fistulotomy before, these are the right cases to choose because you're not going to cause any harm. You just hit the stone and you're not going to cause pancreatitis. And in fact, in this case, the stone was delivered with the needle. So you have to look, as Cecilia and Jafar was discussing earlier, you have to look at the morphology of the ampulla and then decide how you tackle them as well. And then once we were discussing more about the opening of the ampulla, but then now you have to discuss about how you deal with the stones in the duct, what accessories you use. Again, they're both effective using the baskets, or you have the twist and catch with the MedWorks. We have the Rockstar, which is a lithotripter, or you can use the balloon. Any of this can be effective, but sometimes using the fluoroscopy, then you can decide what might be helpful. If you have a duct wherein a stone is completely flushing the duct and there is no space for the basket to open, then baskets will not be effective. For baskets to be effective, you need a duct wherein there is some space between the stone and the duct. Like in the first picture you can see, and then the basket's open, there is space for it to capture the stone. But then in the right side, you can see there's a stack of stones there. It's important to make sure if you're using a balloon in this situation, you don't go up, inflate the balloon and try to get all the stones together. Then you'll stack one over the other and will cause problems. In this situation, it's important that we go in between the stones and then deliver one stone after the other. But then we have some other difficult situations wherein you have a conical shaped duct, you've got a bigger stone on the top. You can't do sphincteroplasty to a quite large extent because it's tapered down below. In this setting, you might not be able to capture the stone with the basket because there's not much space at the top. Or in a situation, in the second case, you can see there's a huge boulder there. Or in the third case, you can see that there is a miridsy with a stone from the cystic duct stump, which is pressing on the common hepatic duct. In these situations, our standard balloon or the basket might not be effective. In these situations, you might need an electrohydraulic lithotripsy or laser to blast the stones, and then use the basket or the balloon to take the stones out. But any of the techniques which we use, whether you're using a basket or a balloon, they're not without complications. So it's important that we know that what complications we can encounter, and especially with a basket, because there's a bit of a tip of the basket projecting outside where the basket is. If you just push the basket without thinking in the line of the duct, sometimes you can perforate the posterior wall. It's important to remember that. Or sometimes, and like in this case, a very freak complication which happened, it's important that recognize this can happen. So this was a patient who had cholangitis, had multiple stones. I had taken the first stone out, and now I'm trying to take the second stone out. It's a difficult stones with the odd shaped. So I'm using the same maneuver, tip down, pulling the catheter out, but if a clockwise stop and pushing the scope in. And then I did exactly like I did for the previous stone. But then you can see that as soon as I did that, I'm bang, you can see this yellowish, I know that I am in the peritoneum now. So what had happened was when I tipped down, the scope hit the lateral wall of the ampulla and then had caused a perforation while delivering the stone. So now I'm just tipping it back up, looking at where the opening is. You can see on the right side, that's the defect. So I'm just taking the ERCP scope out, not to panic, and then just go back with the gastroscope here, and then looking with the gastroscope now on the right side, and then using the over the scope clip, which can close up to about 2 centimeter defects, and then closing the opening, closing the defect, and then using the nasojejunal tube beyond that and start feeding. And this patient responded well, did not require anything. So it's important to also know what can go wrong and then to be prepared for that. So that's going to give a bit of an overview of the stone management from the case selections to also the technical aspects. Thank you.
Thank you, Srisha. So as you are a slave of time, I just make one rapid question that comes from the audience, but it really fits also my questions. When do you perform EUS before ERCP if the patient has improved? So do you do usually in all the patient, even low risk and intermediate risk, or not?
So I think we are fortunate that we have an EUS stacker in the same in the ERCP room as well, which means that any doubt we can use the EUS before ERCP almost in every case. So when the patients has been, even if they've been had a cholangitis, they had a stone, and we have vetted this patient needs an ERCP, but when the endoscopist on the day, when they come to the procedure room on that day, oh, patient is completely well, jaundice has disappeared, then because we got a stack in the same room, we can take the EUS scope first, assess it, and then see if there's a stone still there or not before we do an ERCP. But one thing we need to remember that even if you don't have an EUS stacker in the same room, or even if you don't have an EUS facility, if the patient is well on the day the patient comes for an ERCP, please don't do it. So it's not an emergency. If the patient is well, we can reassess it. We can rebook another MRI, MRCP again if required, or send it for an EUS somewhere else. But what's important is that we don't put a procedure for a patient which is high risk when patient is well. So ERCP is mainly when the patient is unwell is in a situation.
Yeah, I strongly agree.